And hello, everybody. I'm glad to introduce this session. This is a topic that IJIS has been concerned about since actually before I came to IJIS in 2012. They've had a number of initiatives related to this over the years, and a lot of them has been going on around the country outside of IJIS. Initially in 2014, IJIS teamed with the Urban Institute and did a study on justice health use case scenarios, came up with 34 use cases for justice health information sharing, and that was back in 2014, and that was really the first work done along those lines, and a lot of those have turned into successful programs various places around the country. So this workshop is to talk about some of the successes from various aspects of the justice health information sharing situation. The increase in the overdoses, you heard Colonel talking about that, the other drug use, the opioid prescription problem, all have taken a toll on our communities. But because of that, there's been a lot of programs across the criminal justice spectrum to deal with substance abusers when they become incarcerated, including law enforcement and mental health collaboration, jails, doing screening and assessments and treatment placements, and prisons having more extensive treatment programming, and then probation and parole, and the courts ordering some of that. So as all of these parts of the criminal justice system, which aren't very well connected, quite frankly, are trying to treat the same individual, there's a great need for information sharing to make sure there's a continuity of care and the treatment services being provided build on each other and don't become redundant or repeat treatment programs that perhaps didn't work for certain individuals. So with that, we have three panelists today. We have Ron Larsen, who's the program manager at the IJIS Institute, and he manages the RX Check prescription drug monitoring program that BJA funds IJIS to operate. And we have Jim Derry, founder and president of Derry Software, which is law enforcement information management software. And we have Pat Knue. He's the director of the Prescription Drug Monitoring Program Training and Technical Assistance Center at the Institute for Intergovernmental Research. And Pat will be joining us virtually today. So I think you'll enjoy hearing a lot about lessons learned, what's been working, what's not working, and what's working but we need more of, and here's how to make that happen. So with that, is Pat geared up, ready to go? Pat, I'll turn it over to you.
Okay, can you hear me okay?
Yes.
Can y'all hear me?
Can you hear me? Yep.
I can hear you, Rod. Can y'all hear me?
Yes, we can.
Oh, good. Thank you. Sorry I wasn't there able to make it in person, and hopefully there won't be internet issues on my end in Atlanta. I want to apologize for the quality of my camera. Actually, that's a lie. This is the way I look. So I'm going to share with you some information today about prescription drug monitoring programs, or PDMPs, and that's going to set the stage for some of the information I'm going to present about justice and health data sharing later on in my presentation. But we need to set the stage for PDMPs. In case you don't know, PDMPs are designed to facilitate the collection, analysis, and reporting of information on the prescribing, dispensing, and use of prescription drugs within a state, commonwealth, district, or territory. PDMPs are tasked to uphold the laws ensuring access to appropriate pharmaceutical care and the laws deterring prescription drug diversion. Next slide, please. Now, every PDMP has the same overarching goals: ensure access to controlled substance medications for legitimate medical purposes, support educational efforts on appropriate prescribing and dispensing of these medications, support public health initiatives, use of the PDMP data to inform early intervention and substance use disorder efforts, and support investigations of controlled substance diversion and violations of both the medical and pharmacy practice statutes. PDMPs are widely recognized as a valuable tool in addressing the drug abuse epidemic. Next slide, please. PDMP systems maintain a variety of information, as you see. The data collected by all the PDMPs is similar across the country, but there are some variations, and some programs have more information than others. But every PDMP receives data on controlled substance prescriptions. Most of them track Schedule 2 through 5. However, there are a couple that only track Schedules 2 through 4. And there are now some PDMPs that are tracking all prescriptions, not just controlled substances. In addition to the controlled substances, some are collecting drugs of concern. Drugs of concern are medications that are not controlled substances, but the state has determined that these medications are being misused or abused. Some examples would be gabapentin and butalbital. Additional fields that may be tracked include the source of payment for the prescriptions, whether you use cash, insurance, Medicare, Medicaid. Some are collecting the International Classification of Diseases, or the ICD-10 codes, and that's a code that's used to identify the disease or being treated or the diagnosis. Most of them are collecting patient identification, the patient's driver's license, identification card, or some kind of government ID. And there are many PDMPs that also track the identification of the person who is dropping off the prescription or picking up the medications, if that's not the patient to whom the prescription was issued. In recent years, many of the PDMPs are getting data from alternate sources, such as naloxone administrations or dispensings from first responders, information from medical marijuana dispensaries, drug-related arrests or convictions, reports of fatal and non-fatal overdoses, and reports from pharmaceutical drug manufacturers or distributors on different quantities that are being sent to the dispensers. Next slide, please. The earliest PDMPs only allowed access originally to the regulatory boards and law enforcement. Subsequently, access was expanded to the healthcare providers. Also on the slide are some other entities that were authorized to receive the data in the more recent years: medical examiners and coroners, Medicaid, Medicare, fraud, third-party payers, prosecutorial authorities, and drug courts. Next slide, please. PDMP reports that are generated from the data can be based on the needs of the requester. The typical reports have the prescription information showing a chronological listing of the prescriptions by the patient, the prescriber, or the pharmacy, and statistical reports can be generated based on the medication. PDMP reports fall into two basic categories: solicited and unsolicited. Solicited reports are generated when an authorized user makes the request to the PDMP for information. All the PDMPs are engaged in sending out solicited reports. Unsolicited reports are generated by the PDMP based on select criteria and sent to the appropriate authorized user. For example, a PDMP may create an unsolicited report on a patient who may be engaged in doctor shopping. The PDMP will send the unsolicited report to the patient's healthcare providers, possibly law enforcement. It's not proof that anything illegal or anything wrong is going on. It's provided to the healthcare providers to discuss with the patient as they try and determine appropriate care. For law enforcement, it's preliminary information to start investigating potential criminal activity. In addition to those standard reports, the PDMPs have the ability to generate specialty reports, such as statistical reports, drug trends, geographic analysis reports, analysis on medications that may determine whether or not a patient is at risk for overdose, and prescriber report cards, which compare one prescriber's prescribing habits to others within the same geographic area or specialty. Next slide, please. Okay, now that you have a very basic overview of what PDMPs are, I'd like to share with you how PDMPs can be a tool for justice agencies. Next slide. Law enforcement can use the PDMP data to further their investigations, investigations such as unlawful sale of controlled substances or their prescription forms, unlawful prescribing or dispensing, investigation of forgery rings, or doctor or pharmacy shopper rings. Next slide, please. Some PDMP information can also be used in some of the jurisdictions by court officials. Drug courts can use the information to monitor a participant's prescription usage and compliance with the medication regimen. Prosecutors can use the information to assist with their cases on law violations involving controlled substances. Probation or parole officers can use the information to monitor the probationer or parolee's prescription use and compliance with their medication regimen. Next slide, please. It can be used, PDMP information can be used for other authorized entities. For example, medical examiners or coroners can use the information to assist in identifying the cause of death or in a drug overdose case. Public health officials use the information to further their work in prescription drug research, prescription misuse and abuse treatment prevention, and educational efforts. The impaired professional programs use the information to monitor the compliance of their clients. Medicaid, Medicare fraud use it, the information with their drug utilization review boards, identify instances when one of their clients is obtaining prescription medications outside the payment structure, and they're monitoring clients who are restricted to engaging only with a single practitioner or pharmacy. Next slide, please. Now I'd like to share some examples where PDMPs, justice, and health have all partnered together to try and address the drug crisis. Next slide, please. For that, I have three examples: rapid response teams, deflection programs, and overdose fatality review teams. Next slide, please. My first example is going to be on rapid response teams. Now, this is being employed quite successfully by the Pennsylvania Department of Health and their PDMP. Basically, it's multiple agencies working together to minimize negative outcomes such as an overdose risk or loss of treatment due to an action against a healthcare provider. Next slide. Most commonly, these include suspension or surrender of a provider's DEA registration or medical license, the arrest of the provider for controlled substance violations, or retirement or death of a provider. Next slide, please. The justice and health agencies involved coordinate a plan, provide the patients, family members, and the larger community of the options for continued treatment. Ultimately, the goal is to ensure continuity of care and mitigate any negative risk because that doctor is no longer able to treat them. Next slide, please. My second example is a deflection program. The one I'm going to describe is being employed by the Ohio Board of Pharmacy. The PDMP's early intervention program started back in 2018, and this program performs a review of the PDMP data to identify doctor shoppers. Now, once it's confirmed that they're a doctor shopper or appear to be a doctor shopper, they offer them assistance instead of charging them with the felony. Next slide, please. The key to success are the deferred prosecution agreements. The DPA must be approved by a local prosecutor and states that the individual will not be charged with a crime as long as they follow the steps of the agreement. Next slide. My last example are overdose fatality review teams, and these are spreading rapidly across the country. They begin with the premise that overdoses are preventable. So they work to identify where opportunities may have been missed that could have prevented the overdose, and then they develop community strategies to address those gaps. Next slide, please. The critical first step with an OFR team is to gather data about the overdose event. They discuss and analyze the decedent's demographics, information from the death scene, conduct interviews with the family or the investigators to try and understand what was going on in the decedent's prior life prior to the overdose event, and then pull the data together on the individual, and they check the PDMP. Next slide, please. Now, following the analysis, they make recommendations on what could have been done to prevent the overdose. For example, they identify methods to improve investigations, identify policies or laws that should be amended, and develop community-level strategies that hopefully can prevent future overdoses. Next slide, please. So that was it very quickly. I apologize if I went too quickly, but hopefully you learned something about PDMPs, justice, and health partnering together. This is our contact information for the PDMP Training and Technical Assistance Center. You can scan the QR code or go to our website if you want more information, but we're here to provide assistance to anyone interested in PDMPs, so please don't hesitate to reach out to me. I assume we're doing questions at the end, so I will turn it back over to Ron.
Hello, I'm Jim Derry with Derry Software, and we provide technology to law enforcement, but that's not why I was invited here today. In my previous experience, I worked in Tennessee at the Tennessee Dangerous Drugs Task Force, where I managed a methamphetamine intelligence system first, and then that kind of morphed into adding in overdose information as the drug problems changed. And during that time, I worked in quite a few information sharing projects. We really had a focus to get information from and back to local law enforcement across the state. So we had to get everybody involved in that, which is a pretty big challenge and a constant battle you have to do. And then we wanted to work with other agencies, especially as we got to the overdose, particularly health and mental health, as they have a stake in it as well. Also, community coalitions are the partners that we worked with. And then we worked with folks like ROCIC, Administrative Office of the Courts, on identity sharing projects with others when information sharing didn't work out. And my focus I guess, in life is really helping the local law enforcement agency. So you might say I'm a little slanted there, but the truth is I'm a lot slanted there. So I want you to know that up front. And, oh yeah, let's go to that next slide right there. I forgot y'all had my slides too. So, hey, who's the slide guy? Okay, thank you. All right, I'll be looking at you from now on. Hey, there's a few things that I want to address here, particularly when we talk about information sharing. And the first is challenges. What are we trying to do? What kind of problems are we trying to solve? And really, when we think information sharing, we get stuck a lot in saying the problem is sharing this information. But really our problem, as an example, is overdoses. And we got people overdosing, and then we got a whole lot of people dying from overdosing. Back in the meth days, we had all kinds of people on meth. In Tennessee, we had hundreds of meth labs every month, but they didn't die near at the rate that they're dying now. And as long as they're alive, there's hope. But when they die, there's no more hope for them in the future. So it's a really big problem, and it's important, and I know we all do, but I just like to remind us of that it's important of what is our actual mission. And in this case, we'll use the example of overdose because it's so prevalent. And then when we get our mission, well, what's our goals? And when we talk about information sharing, you know, law enforcement has a goal, health has a goal, mental health has a goal, and mom and dad got a goal. And sometimes these things are different. So we really have to say, well, the way to accomplish my goal is these steps or this information. And somebody else's discipline says, no, this is how you have to solve it. No, this is how you have to solve it. And, you know, all of them can be right. I hate to use that word, but all of them can be valid is a much better word to use. But how are we going to solve all these problems or all these sets of problems or accomplish these goals when we share information? Well, that gets us to our next challenge, and that's relationships. So relationships, when I have a relationship, you're in the head. Back up, thanks. That's all right. I still love you. I want you to know that, okay? Hey, when we get to relationships, we got to have trust, because when we have trust, we're going to lose control of our information. We used to not love, but we used to have a little fun going around in Tennessee talking about sharing information, which means, well, I got to give you some of mine, and you got to give me some of yours, just like on the playground when we were in kindergarten, right? And in law enforcement, I heard it said in the last presenter, and Brian may have said a little while ago, as soon as I share information, well, somebody's going to steal my case. Brother, there's so many drug crimes out there. You don't have to worry about stealing a case. You'll get 10 more tomorrow, right? So, but it's always a problem that you've got. And then when we go interdiscipline, well, I got to share with this health person or this mental health person or these community people. Well, it gets a little harder and harder. So we got to have a relationship, and we got to have trust, and it's just a challenge and a problem that we got to overcome. And then on the bottom, because IT people really get my goat, I want you to know, and it's always technology. Oh, well, you can't do this, or you can't do that, or it's going to cost you $50,000 and take 6 months just to add one item to a list in a drop down. And we've all heard that, and we all know it, and we all know it's bogus. But we've all had those things, and how we're going to overcome these problems, and how we're going to be able to talk with our technology people about actually doing something for technology. So those are the things that I kind of look at when we want to solve information sharing problems. Next one, please. And I just want us to think in terms of opportunities we get from information sharing, because it's hard to do and it's hard to solve all these problems. So what's the result? What's the benefit? Well, one thing is, if I've got information, hopefully I'm an expert, or I've got some experts who can analyze or do whatever I need to do with this information. But if I'm at a state or a federal level and I share information with locals, I now go from one or a few experts to hundreds or thousands of experts. And they've got the local, on-the-ground expertise to know exactly how to handle that information in a lot of cases when it comes to it. So it's a great opportunity to share information locally on getting a lot better results. I just can't tell you how excited I am about the opportunity to do that. And then we look at the strategic view. When I'm back here at the state or federal level and I've got all this data, I've got a strategic view of the problem and a much better strategic view than the locals. And I'm in a much better position to make policy, take actions, or decide plans, devise systems to handle this information. But when I'm at that local level, I got that tactical view to take immediate action on it and do something right now. So it's better for both of us if we both have the information. It's just a really big and important deal to always think to get that information local. I've got great ideas. It's the next one. We got tons more ideas when we get more people out there. Some of them will be bad, I'm sure. Some of them will be really good. Limited disciplines. And what I mean by that is, if I'm law enforcement and I say, well, I'm going to have all the information just within my community, maybe it's going to go up and down from local to FBI, well, it all stays there. But as soon as I spread that out, then I'm sorry, I'm waving the wrong hand around. As soon as I spread that out, I get multiple disciplines involved so they can all accomplish their goals, which complement me accomplishing my goals. And then the last thing is dissemination from the state or federal and to decision-making at the local. It's a great concept. Anyone who's ever done any local operations in the military knows exactly how this goes. And I'm going to use Brian here as an example. I should specify FBI Brian, not one of those other Brians. He gave us 2 examples of initiatives that he's done at FBI, and they were so exciting to me because what he did was he took information that he had at the federal level, and his strategic view of that was, how are we going to solve this problem? He said, well, we're going to get it down there to the local level, whether it be a 911 call or whether it be a tip to local law enforcement, so hopefully they'll follow up, and they can take that information and make a tactical decision on the spot. When it goes to 911, someone is dispatched and they get there and they assess it right there on the spot. It's immediate. When it's a tip, Lord willing, and hopefully they're going to follow it up passionately and run that thing to ground, and the same thing is going to happen, because some tips are just, you know, nips, and some tips are really big deals, as we all know. So it was just great, his examples, and you can take everything on this slide and use those two examples that Brian told us about on the 911 and on the tips and apply them. And these are the reasons, because he had different goals and different missions in both of those. And these are the reasons for sharing information locally. And you know, I want to say something real quick here. I know I'm preaching to the choir, but I just like to preach, all right? So these are the big deals for information sharing. Next slide. Obstacles. We got problems. I wanted to put one at the top that's been a challenge that I experienced in more than one meeting. Well, the law enforcement takes data set or problem X and calls it a crime, and someone from another discipline says, well, that's a disease, and why are you trying to prosecute my disease? And I just want you to know that we all need to do what we're here and we're trained and we have expertise to do, and we've got to share that information, but sometimes it gets a little hard and a little tricky, and we've got to talk to each other about these things. Another one is laws prohibit. We got all kind of reasons why we can't share data. And so I've been in these conversations. Well, laws prohibit. Well, no, they don't. Well, yes, laws do. And then, well, we need to change laws. And there's all kinds of things that are obstacles and barriers such as these. Another one is, this is the way we've always done it, established methods. I can't tell you the times I've talked with local law enforcement about, you know, going out there like Joe Friday with your little notepad, if you remember Dragnet, trying to solve an internet crime, right? Say, look, we got to do different methods here now and different ways of doing things, including in information sharing. And then I'm back to the technology hurdles. Proprietary information, the vendors say, well, we can't share information, you can't do this and you can't do that. I remember last year I called a vendor about sharing information, and they said, well, we don't talk to vendors. I said, well, you are a vendor, buddy. And he didn't like that. I didn't get anywhere. I won the argument there, but I lost the information sharing, so it wasn't really a win at all. But these are the things that I want to talk to you about, our information sharing and the things that I've seen happen. We've got a lot of opportunities to succeed, and we've got challenges. But going back to that first slide, if we get that relationship and that trust, and we remember our goal, then we're just going to look for solutions. And that's all I've got to say.
My name is Ron Larsen, and I am a prior law enforcement officer in Utah and a PDMP administrator for the state of Utah. I came to work for IJIS to work on what's called the RX Check initiative. And that is a database process to which data can be shared from healthcare entities to from the state PDMP and then interstate. Where does that come into this discussion that we've just been talking about? Earlier, you heard Pat talk about what a PDMP is and some of the different functions and information that is within the PDMP. And how does that impact law enforcement, especially in the day of HIPAA, where now you're concerned about patients' health information and what you do with it. If it becomes available to you, how do you deal with it? All of these kind of things. But each one of those pieces of elements of data is very important when you consider the scope of providing health across the board. When we talk about that, I go outside, I look and see the individuals laying on the streets. We all see that. They didn't just choose to lay down on the streets. Something intervened in their life. Brian said earlier there's an event. I was telling Jim earlier, I was speaking with a physician. We were talking about substance abuse. And I said, you know, I never understood how somebody just woke up and said, I'm addicted to heroin today. And he says to me, I do, and there is a reason. How many children today are being born in a situation of substance abuse? He says, stop and think about that, and then think about the fact that they're still being cared in that substance abuse environment. They are addicted at birth. So the beginnings of their life means that they're saddled with the addiction of an opioid. So if we are going to really try to make hurdles of the opioid epidemic, of the substance abuse epidemic, then we need to start looking at all of the data, the real data. Unfortunately, we have states, my home state said, we want to protect it. We don't want everybody seeing it. Only a few healthcare people should be able to see it. We're going to take law enforcement out of the realm of being able to have controlled substance information. And Utah is not the only state. There are several states that have taken that approach, making it a requirement for a search warrant. Some ways that's not so bad. Data must be protected. Data should be protected. But data also must be shared. It's important if we're going to really work through the crisis that we're now undergoing and looking at the hundreds of thousands of individuals who, and I'm going to say this, so no fault of their own, have become addicted, either through the course of birth, as I just mentioned, or being treated for injuries, and then all of a sudden finding themselves subsequently addicted to a substance they never thought they would be. They can't get the substance by legal means anymore as a prescription, so they go to the street. And I've heard that in my career in law enforcement time and time again. If we as first responders are going to be able to try to help and deal with substance issues, with mental health issues, and they're generally always tied together, we need to be able to have information. That goes back to us going to our local elected officials, working with them to try to get our state elected officials to make changes to some of these laws. Again, we have HIPAA. Is that data going to be permissible to you? Where we are bringing more healthcare providers into the justice programs, many of your large municipalities now are bringing in healthcare providers for first responding when they've been identified as an individual with a mental health issue. Information is critical to them. That information often can be coming from a prescription drug monitoring program. As Pat had mentioned earlier, there's court information. There's overdose information. There's, in many states, cannabis information. And that's something that's growing even greater today. All of those types of data can be useful to somebody who's trying to help and provide resources to the individuals that we're all talking about. The whole purpose of this is to help individuals try to get through their addiction, reduce the opioid instances, and help people find and live better lives. And so I make my plea for everybody in this room, because there's a lot of you are in the tech sectors, a lot of you are in the government sectors, but you all speak to your local elected officials and your state officials. It's those individuals that can help open up some of these doors that broadens that data sharing. Just as Brian was saying, for data sharing and information. If we could take meaningful data, identify law enforcement agencies, individuals within those groups that could receive that data, that would use that data in both a law enforcement, but in a health care manner, that would help individuals, would we have an impact on crime? I've never met anybody who had a burglary that didn't say at some point, oh, I found out they stole my stuff for drugs. I mean, how many people go in, and I'll say take out some kids, exploratory, but when you're dealing with adults, they're breaking into your home, they're robbing you, generally because they're needing to get money to buy drugs, whether it be illegal substances or prescription substances. It's all to feed their need. And that's where we make some of our biggest impact. So as a PDMP administrator and knowing what data resources is out there, my plea is to you is to talk to your local officials and get them interested. There is information here that sometimes is left literally untouched, and then there's other information that could be added to this. such as one of the things I've talked about, PDMPs could collect toxicology reports. Would it be beneficial to a provider to have a resource for toxicology? Would it be useful to a first responder who is eligible to obtain some of this information to know toxicology of a person's past? These are different things that, while we're not trying to criminalize an individual, we are trying to help individuals. And it's through all of this data sharing that literally goes across law enforcement and healthcare lines.